Hello, my name is Patricia Dykes, and today I'll be talking about using fall risk assessment tools in care planning. Thank you for joining this webinar. And before I get started, I'd like to tell you a little bit about myself. I'm a senior nurse scientist and research program director in the Center for Nursing Excellence and in the Center for Patient Safety, Research and Practice at Brigham and Women's Hospital. Our team conducted the first fall prevention trial in acute care hospitals that showed a significant reduction in patient falls. Today, I'll share with you some of the evidence that we learned during that study. Today, we're going to talk about fall prevention. Specifically, we'll talk about universal fall precautions, fall risk factor assessment, fall risk assessment tools, and how to use fall risk assessment tools in care planning. Please make note of your questions as we go along. Your quality improvement specialist will follow up with you after this webinar to address them. We'll start by talking about universal fall precautions. Specifically, we'll address the features of universal fall precautions. We'll give some examples of universal fall precautions, and then we'll talk about how you implement universal fall precautions. Universal fall precautions are the cornerstone of any hospital fall prevention program. They apply to all patients at all times, and consistently applying universal fall precautions to all patients can help eliminate preventable falls that are caused by environmental conditions. So what are some examples of universal fall precautions? Well, one is to keep pathways clear, especially pathways that lead to the bathroom. Always wipe up spills immediately. Provide access to the call bell for patients who are in bed or in the chair in their room. Provide non-skid footwear. To implement universal fall precautions, all hospital staff who interact with patients need to be trained. And so this includes direct caregivers, such as nurses and doctors, but also indirect caregivers, such as clerical and environmental staff. By training all hospital staff who interact with patients, creates an environmental culture of safety within the hospital that really values fall prevention. Now that we've reviewed universal fall precautions that apply to all patients, we're going to talk about risk factor assessment, which helps us to identify which patients are at risk for falling and specifically which factors place them at risk. We're going to talk about features of fall risk factor assessment. We'll talk about using assessment tools universally, and then we'll talk about the basis for risk factor assessment. A standardized tool and process for completing fall risk factor assessment is a prerequisite to implementing an evidence-based fall prevention program. Fall risk factor assessment helps you to first identify patients who are at risk for falling. It also provides a baseline measure of patient-specific areas of risk. It aids in clinical decision-making and informs personalized preventative measures and care plans and communication strategies. And it also links strategies to counteract any risk factors that have been identified. So once you have this information, it really can aid you in clinical decision-making because it's based on the patient-specific areas of risk, and you can use that information to tailor or personalize a plan of care that is specific to that patient. A personalized intervention plan is one that directly links the fall prevention strategies to any identified risk factors. So fall risk assessment needs to be standardized and ongoing. We need to ask each patient the same questions the same way, and by doing so, staff won't miss any risk factors. To support universal use of a fall risk assessment tool, all nurses should be properly trained in use of the risk assessment tool to make sure that they're familiar with what types of responses indicate a positive risk factor. So it may seem obvious, but let me give you an example from a commonly used tool, the Morse fall scale. One of the items on the Morse fall scale is mental status. And at face value, one might assume that only confused patients have a positive mental status. However, positive mental status on the Morse fall scale refers to both confused patients and patients who are completely alert and oriented, but they don't follow instructions to wait for assistance before getting out of bed. And so to really know that distinction, a training is required. So the basis for fall risk assessment is first and foremost a validated fall risk assessment tool. By creating your own tool or changing an existing tool can really limit your ability to predict patients' risk for falling. The frequency of the fall risk factor assessment should be with change in patient status at a minimum, but it's typically defined in the hospital policy. In many hospitals, fall risk assessment is done at least once a day, but it can be done more often for acutely ill patients or less often for patients who are more stable. But regardless of what your hospital policy says, the fall risk assessment can always be done more frequently based on the nurse's clinical judgment. Now we're going to talk about risk factor assessment tools. In this section, I'll cover the criteria for selecting fall risk assessment tools. We'll look at some common fall risk assessment tools and talk about the limitations of all fall risk assessment tools. I'll talk about some strategies for using fall risk assessment tools, and then we'll also talk about some of the limitations of fall risk assessment scores. So as I mentioned earlier, fall risk assessment tools should be selected based on their scientific validity. So for example, the tool should have been prospectively validated in more than one population, and this means that the tool should be tested on a sample that's different than the sample that was used to develop the tool. There are tools that have been validated on more than one population are more generalizable. For example, here at Partners Healthcare, we have many different types of hospitals and patients, so we looked for a tool that was tested in many different settings. The tool should also have published sensitivity and specificity analysis. So this tells you how well the tool is going to predict patients who are at risk for falling. It also discriminates those who are not at risk. The tool should also have good face validity. So a clinician should be able to look at each of the scale items and have a good idea what they mean. And it should also have good inter-rater reliability, and that means that if the tool is completed by two different nurses on the same patient, they should identify the same areas of risk and they should get the same score. And then finally, there should be a transparent, simple method for calculating the score. You shouldn't need a calculator to calculate a fall risk assessment score. Some examples of fall risk assessment tools that have been prospectively validated and that do meet the criteria that we just talked about on the previous slide are the Stratify tool, the Schmid fall risk assessment tool, and the Morse fall scale. Today, during this webinar, we're going to mostly focus on the Morse fall scale. One thing to keep in mind about fall risk assessment tools is that no tool has perfect predictability, and even patients at low risk require some intervention. Some important strategies for using fall risk assessment tools include, as we mentioned, use a valid and reliable tool. Staff do need to be trained in how to properly use risk assessment tools, that all patients should be assessed, and that the assessment is just the first step. Based on the assessment, intervention should be tailored to address each of the areas of risk that are identified for that patient. And then keep in mind that all patients who have fallen once are more likely to fall again and under similar circumstances. So plan appropriately, understand what were the circumstances of that fall and what could be done to prevent a similar fall. There are some limitations of fall risk assessment scores. So some assessment tools include a scoring system to predict fall risk. If you base a patient's individualized care plan on their fall risk score alone, their care plan will not be tailored to the risk factors. So instead, you should use assessment tools to identify the areas of risk, but not rely on the scores. So for example, a patient might have mental status alteration, or they might have a gait disturbance, but the interventions for mental status are different than they are for gait disturbance. So it's important to not only know what the score is, but what the areas of risk that are positive are. So now we're going to talk about using fall risk assessment tools in care planning. We'll talk first about the types of falls and how to prevent them, and then we'll talk about the risk factors for falls that are identified by the Morse Fall Scale. Dr. Morse, in her book entitled Preventing Patient Falls, describes 3 different types of falls, and the first is accidental falls. Accidental falls occur in patients who really have no risk factors for falling. They're usually caused by an environmental hazard or an error in judgment, and these account for about 14% of falls. We prevent accidental falls by implementing universal fall precautions and using these precautions with all patients. The second type of fall are unanticipated physiological falls. Now, these are falls that occur in patients who have no risks for falling, and they're caused by physiological changes that can't be predicted, such as a seizure. Unanticipated physiological falls account for about 8% of falls, and these are the most difficult to prevent. Some may not be preventable. The third type of falls are anticipated physiological falls, and these falls occur in those who have a risk for falling. The Morse Fall Scale includes 6 items that can predict anticipated physiological falls. These types of falls account for 78% of falls, and they can be prevented through a fall risk assessment using a validated tool like the Morse Fall Scale and tailored care planning and intervention. It's important to note that by implementing a fall prevention program that includes universal fall precautions, fall risk assessment, and tailored interventions, that most falls, about 92%, are preventable. So what are the risk factors for falls identified by the Morse Fall Scale? The first is history of falling. The second is secondary diagnosis or comorbidity. The third is ambulatory aid. The fourth is IV therapy or heparin lock. The fifth is gait. And the sixth is mental status. And we'll go through each of these in detail over the next few minutes. Now we're going to talk about using the Morse Fall Scale in care planning. We'll start by reviewing the Morse Fall Scale and each of the areas of risk. We'll talk about the steps that you need to take to incorporate fall risk assessment into your clinical workflow, and we'll review interventions that are appropriate for each of the areas of fall risk. We'll then put it all together using a case study, and then finally we'll summarize some of the key principles of using fall risk assessment as a foundation for an evidence-based fall prevention program. Here's a screenshot of the Morse Fall Scale. So note, once again, there's 6 areas of risk, and we will go through these areas of risk in the next few slides in detail. So what are the steps to take to use the results of the fall risk assessment and care planning? Well, first of all, we need to review the areas of risk that are identified by the Morse Fall Scale for each specific patient. Based on the areas of risk that we identify, we then need to select interventions to address each area of risk. We need to communicate this tailored or personalized fall prevention plan to all staff who interact with the patient. We also need to share the plan with the patient and his or her family members. So the first area of risk on the Morse Fall Scale is history of falling, and that's in the past 3 months. For patients who do have a history of falling, we want to use safety precautions. We want to communicate risk status via the care plan, change a shift report and signage to the rest of the team. And we want to document the circumstances of previous falls, because remember, patients who have fallen previously are more likely to fall again and under similar circumstances. The next area of risk is secondary diagnosis. So for secondary diagnosis, think about the factors that might increase risk for falls related to the multiple medical problems that patients often have. So for example, symptoms related to an illness, being on multiple medications, any side effects that they're experiencing, such as dizziness or frequent urination and unsteadiness, and vision problems. All of these things could cause the patient to trip or to have trouble getting to the bathroom by themselves, and they do increase their risk for falls. The next area of risk is ambulatory aid. So if the patient needs an ambulatory aid, there should be one available for them at their bedside. Always review the dangers of using furniture or hospital equipment as ambulatory aids with patients. So as you all know, most of the furniture in hospitals is on wheels, and when patients use that as an ambulatory aid, they're very likely to fall. And for patients who don't know how to use their ambulatory aid well, think about a PT consult. The next area of risk is IV therapy or heparin lock. And so for patients who are getting IV therapy, the intervention would be thinking about whether they need a toileting schedule or rounding schedule due to the fluids or the medications that are infusing through their IV. Tell the patient to call for help with toileting and review the side effects of the medications, the IV medications with the patient. The next area of risk is gait. And if you read Dr. Morse's book, she makes the point that with gait, you really have to observe the patient walking. And you'll be looking for either a normal, a weak, or an impaired gait. A normal gait is a patient who's walking with their head erect, their arms are swinging freely at the side, and they're striding without hesitation. A patient with a weak gait is stooped over. They may be able to lift their head without losing balance. If furniture is needed, they use it to guide themselves, but they don't rely totally on it. They very often have short steps. They may shuffle. But patients with an impaired gait have difficulty even getting up from the chair. Very often they need to use their arms. It may take several different attempts before they're actually able to rise. And when they do get up to walk, their head is almost always down. They're watching the ground while they're walking, and they cannot walk without assist. So if they don't have their device, they are going to grab at furniture or whatever is available, and their gait is typically short and shuffling. So for patients who have a weak or an impaired gait, they need help getting out of bed. They are at risk for falling if they get up alone. And also consider a physical therapy consult to assist with gait training. And then the final area of risk is mental status. And so for the mental status test that's recommended as part of the Morse Fall Scale is ask the patient, are you able to go to the bathroom alone or do you need assistance? For patients with a normal mental status according to the Morse Fall Scale are patients whose responses are consistent with the order or the Cardex. An abnormal response is a patient who overestimates or forgets their limitations. So if the patient's response is inconsistent with the orders or unrealistic, so a patient that needs help to get up is having medical symptoms or problems that really require assistance with getting to the bathroom, and they say, oh no, I can go by myself, that's the patient who has a positive mental status. And so for that type of patient, you would consider using a better chair alarm, because if they do start to get up, you want to know it. You also want to place these patients in a visible location. So if they start to get up alone, they're in view and they can get help. You also want to encourage family presence. So family can let you know if they need help, and you can assist them with going to the bathroom. And this type of patient also, we need to do frequent rounding to see if they need to go to the bathroom or if they need to get up so that they can be assisted with that process. So now that we've reviewed all of the areas of risk on the Morse Fall Scale, we're going to read through a case study and talk about how we would complete the fall risk assessment on this particular patient and how we would use that to do a care plan. So an 82-year-old man with type 2 diabetes was admitted to the telemetry unit with chest pain and shortness of breath on exertion. On admission, the patient was alert and oriented to place, person, and time. He had an IV of half normal saline, and he was placed on a cardiac monitor. During his admission interview, the patient reported that with his cane, he was independent with ambulation and transfers. However, the admitting nurse noted that the physician's order was for ambulation with cane and assistance. With further questioning, the patient reported that he had fallen at home several times over the past year. Most recently, he fell last month. As the nurse assisted the patient to the bathroom, she noted that initially he used the bedside table and other furniture as a guide and needed to be reminded to use his cane. But once he was given his cane, the patient walked with short, steady steps to the bathroom. So now let's look at the Morse fall scale and talk about how we would complete the Morse fall scale based on this patient's assessment. So we know that the patient said that he has fallen several times over the last year, most recently in the last month, and so history of falling is positive, so we say yes there. Secondary diagnosis, the patient does have multiple medical problems, so yes to secondary diagnosis. We learned that the patient walks with a cane. However, the patient's first response is not to grab the cane, but to grab furniture. And so instead of rating this patient as this patient's ambulatory aid as a cane, we rate it as furniture, which is a 30, because as I mentioned, patients who go first for the furniture are at much higher risk than patients who tend to use their assistive device, since the furniture in the hospital is on wheels. This patient does have an IV, and so that area of risk is positive. And the nurse did an assessment of the patient when he was walking to the bathroom, and the patient, once he had his cane, the ambulatory aid that he's supposed to use, had a weak gait. And so the weak gait is an additional 10 points. And then for mental status. So while this patient seems to be alert and oriented, he does overestimate his ability and believes that he's safe to go to the bathroom by himself. And so mental status is positive. And so if I was this patient's nurse, I would develop a plan of care to address each of these areas of risk. Once I had that plan of care, I would review it with the patient. And if the family was there, I'd also review it with the family. And I'd communicate the plan of care to the team to make sure that it was consistently implemented. Because in order to prevent falls, we need to first do a fall risk assessment. We need to develop a plan that addresses each of these areas of risk that are positive. And then we need to consistently implement the plan with the patient. So assessment tools should be used by staff nurses. They should be used with clinical assessment and medicine review. Assessment tools should be used to identify a patient's fall risk factors and also to plan care that addresses each of these factors. If your hospital has an electronic record system, integrating these tools into that system is a good way to do it. It should be part of the workflow, what nurses are doing every shift with their patient. So just to review, today we talked about universal fall precautions and how these need to be implemented for all patients, and that universal fall precautions prevent accidental falls. We talked about fall risk factor assessment, and we talked about some of the prospectively validated fall risk assessment tools. We talked about how to use fall risk assessment tools, specifically the Morse fall scale, in care planning. Thank you so much for being such great listeners. Please refer any questions to your QI specialist. On this final slide, we have a list of fall prevention resources that will be useful as you implement your fall prevention programs. Thank you very much.